Hello everyone, this is Dr. Madhusudan Rao and the program I teach medical students. The topic of today's lesson is cerebral palsy. Cerebral palsy is said to be the most common motor disability in children. In this topic, today I'm going to cover the etiology, clinical manifestations, that is the classification of cerebral palsy, and its management. Cerebral palsy is a group of motor syndromes as a result of disorder of early brain development. That means injury occurring to the developing brain. That injury is said to be non-progressive, and the etiological factors may include developmental anomalies, genetic or chromosome abnormalities, metabolic, ischemic, or intrauterine infections. It is said to be static encephalopathy, included under the topic status encephalopathy, as it is said, the injury that occurs is non-progressive. Motor dysfunction with variable occurrence of seizures, sometimes associated with the other morbidities like visual and auditory disturbances, sometimes complicated by seizures, feeding problems, speech and communication problems, and behavioral abnormalities. Okay. This picture shows the medial surface of the cerebrum, cerebral cortex, and other subcortical white matters. This slide shows the classification of cerebral palsy, which can be grouped into the spastic, dyskinetic, and ataxic. That all depending upon the area of the brain that is affected due to injury. This picture shows the ataxic type of cerebral palsy, where this child is very unstable and not able to maintain the balance of the posture. This picture shows the spastic type of cerebral palsy, the hemiplegic type, diplegic type, and quadriplegic type. The clinical features of which we are going to talk in detail. This picture shows the sort of ataxic type of cerebral palsy, and we are testing with the finger nose test to demonstrate coordination. Etiology. The prevalence of cerebral palsy is said to be ranging between 1.5 to 2 per 1,000 live births. The antenatal factors results in the developmental anomalies of the brain. Intrapartum factors like asphyxia accounts about 10% of the cases. Maternal antenatal infections and low birth weight and the prematurity is said to be the most significant factor for cerebral palsy. And it has been demonstrated serum cytokine levels in the fetus are very high. There is evidence of periventricular leukomalacia in the children with spastic diplegia. Classification. It is classified topographically as spastic, extrapyramidal, and mixed. Spastic cerebral palsy again subdivided into hemiplegic, diplegic, and quadriplegic. In spastic hemiplegia, there is involvement of one half of the body with hypertonicity and hyperreflexia and positive wave scan associated with loss of power. In diplegia, lower extremities are more affected than the upper torso with spasticity and hyperreflexia. Quadriplegia is said to be a more severe form of spastic cerebral palsy, wherein all the four limbs are affected equally with hypertonicity, and hyperreflexia. Extrapyramidal type is associated with the initially hypotonia, followed by hypertonia like rigidity with involuntary movements. There could be a mixed form of cerebral palsy. Coming to the clinical manifestations in detail. Spastic hemiplegia. As I said, in spastic hemiplegia, there is one half of the body affected. Okay? Right? There is hypertonicity of the one half of the body, that's right upper as well as the upper and the lower limbs, and one half of the body. And seizures are more common, affecting nearly 25% of the individuals, associated with intellectual impairment. Okay. And there is hand preference is observed by the parents because baby uses one hand when compared to the other hand. Okay. Then there is history of delayed walking, and the child is said to walking with the arching the lower limb and lifting the limb away from the ground. That is called circumduction gait. Okay. In order to clear the ground, the patient lifts the limb, lower limb, and moves forward with arching outside. The upper limb is adducted, flexed at the elbow, and flexion at the wrist with hypertonicity. This is called hemiplegic posture. So, weakness associated with hypertonia, hyperreflexia, with extensor plantar, involving one half of the body, is the feature of spastic hemiplegia. MRI of the brain shows cerebral atrophy on one side. Okay. And the most common cause is stroke, that is thromboembolic phenomena, involving one of the great vessels, say the middle cerebral artery or its branches. Coming to spastic diplegia. In spastic diplegia, lower limbs are more spastic than the upper limbs. It affects mostly the lower limbs more than the upper torso. There is history of delayed walking. Mother says the baby used to crawl with moving the upper limbs and dragging the lower limbs. This is called commando crawl. And there is hypertonicity of the adductors of the hip, and mother may feel more difficulty to hold the baby and wear the diapers. To put on the diapers is a difficult task for the mother because of the spasm of the adductors. And there is scissoring gait. And intellectual impairment is not noticed. No, there is no intellectual impairment in these patients with spastic diplegia. Because spastic diplegia is due to the injury to the periventricular white matter, sparing the cortex. Seizures are less common. There is hypertonia, hyperreflexia, and positive Babinski in both the lower limbs. And brain tissue shows periventricular leukomalacia on MRI with cyst formation. Coming to spastic quadriplegia. This is the most severe form of cerebral palsy. It involves all the four limbs associated with mental retardation, seizures, and child suffers more amount of mobility with swallowing difficulty and aspiration syndromes. There is spasticity and hyperreflexia involving all four limbs with plantar extensor. There is impaired intellect, speech abnormality, and visual disturbances. And there is marked delay in the milestones of development. Rather, most of the children, they do not develop speech because of pseudo-bulbar palsy. And pathologically, the lesion involves periventricular leukomalacia, okay, multicystic cortical encephalomalacia. There is diffuse damage of the cerebrum involving the cerebral cortex, that is cortical matter, and the descending white matters in the subcortical areas with multicystic formation. So there is, because of the extensive injury involving the cerebral white matter as well as the gray matter, and the patient presents with the intellectual abnormalities, speech delay, and seizures. And spasticity involves the all four limbs, and also the patient suffers from pseudobulbar palsy with swallowing difficulties. And most of the time, the seizures are resistant to treatment in these children. Extrapyramidal or ethioid form of cerebral palsy. It is rather less common, commonly seen with the babies who suffer from kernicterus. And the subcortical white matter is affected, involving the basal ganglion. Initially, it presents with hypotonia, with poor head control and marked head lag. And few years later, child develops variable hypertonia, rigidity, and dystonia. Okay, there is truncal ataxia, and there will be feeding difficulties, tongue thrust, and drooling. And most important finding, you see the absence of upper motor neuron signs. That means there is no hyperreflexia or Babinski sign. Seizures are uncommon. MRI shows status murmuratus involving the basal ganglion. Diagnosis. The detailed history is very important besides the complete clinical examination. Okay. Then take the MRI. MRI is more sensitive when compared to the CT. Subject the child for metabolic screen to exclude other causes of metabolic disorders. And test for hearing and vision. Well, management of these children with cerebral palsy is with a multidisciplinary approach. You should have the physiotherapist, okay, pediatrician, and neurophysician, right? And should provide the physiotherapy, special education, and parental counseling is very important in order to have the psychological support to care, to provide adequate care and support to the suffering children. And children should be provided with the special education to suit their intellect. And drug therapy in order to improve the movement and motor function. The functional disability can be controlled to some extent by appropriate physiotherapy, and education should be provided with according to the intellectual development of the child. Then there are certain drug therapies that are used for improving the motor tone and reducing the motor disability. That is dantrolene, baclofen, benzodiazepines, L-dopa when there is involuntary movements, and botulinum toxin to reduce the hypertonicity, and seizure therapy in order to reduce the occurrence of epileptic seizures. Well, besides, there are certain surgical procedures that are taken to have the tendon lengthening procedures to reduce the disability. The contractures and the deformities are really problematic for the children to improve their motor ability. Well, there are certain indications for, say, surgical indication to reduce the involuntary movements or and motor disability related to the rigidity, tremor, sometimes extrapyramidal syndromes in ethitoid or choreoethitoid type of cerebral palsy. So there are interventions like deep brain stimulation that are being advocated for the children with movement disorders. Well, this is all a brief note on the cerebral palsy, its clinical presentation and the management. Thank you very much for patient listening, and we'll meet you again in the next class. Until that time, thank you and bye-bye.